I'd like to introduce Dr. Chodosh. Dr. Chodosh is the Cogan Professor of Ophthalmology in the field of cornea external disease at Harvard Medical School. He is an ophthalmologist and a clinician scientist whose work is focused on molecular virology, genomics, and viral pathogenesis. And this background has given him a unique perspective in the field. As such, Jim has been the perfect spokesperson for the AAO on this matter. And today he's going to provide an up-to-date overview on COVID-19, virology, and public health.
Thank you so much for the opportunity to speak this morning. I think all of you know a lot about this virus and the disease it causes, but just briefly, coronavirus is named because of its crown-like appearance on electron microscopy, and this is due to the spike protein which projects externally from its viral envelope. The spike protein is the ligand binding to ACE2 receptors on mucosal epithelium, and this virus has a positive sense single-stranded RNA genome, much like dengue virus, West Nile virus, and the cause of the common cold, the rhinovirus. And it has about 80% sequence identity with the original SARS virus. This cute little creature is the likely origin of the virus, the horseshoe bat. And this is a artificially colored electron micrograph of the virus in lung tissue. Kind of frightening to me personally. These are nuclei, and these are in red are the viruses. But you may not know that the virus also infects heart, brain, GI tract, kidney, and it can cause a coagulopathy leading to thrombotic stroke, even in young, otherwise healthy appearing patients. And recently there was a newly reported syndrome, rather rare but serious, the multi-system inflammatory syndrome in children. I'll mention that again in a moment. Ophthalmologists have been looking for manifestations of this disease, and it appears that in 1% or less of patients with COVID-19, they can develop a follicular conjunctivitis that tends to be benign and short-lived. However, there are reports of pseudomembranous conjunctivitis in a couple of case reports, and one perhaps partly convincing report of epithelial keratitis in a patient with SARS-CoV-2 in their tear film. This is a list we've all seen. All of us who report to hospitals have to report negative findings on all of these symptoms, but you may not know that elderly patients with COVID-19 may be quite ill and show only lethargy and confusion and have sudden death from there. And children with high fever and a rash mimicking Kawasaki's disease can have this multi-system inflammatory syndrome in children, which can cause fatal heart arrhythmias and sudden death. It's a frightening number to see that there are almost 2 million cases reported in the US, with now approaching 115,000 deaths. And this may be an underestimate. There are patients or persons who were never tested and died at home. And we also know that healthcare personnel have not gone unaffected. This estimate of the C.D.C. 371 deaths is clearly an underestimate. If you do the math, it appears there could be as much as tenfold more, perhaps 3,000 deaths among healthcare providers just in the United States. On the left is a list from the American Academy of Ophthalmology of ophthalmologists who are known to have died of COVID-19. This is certainly not a complete list. And on your right, a picture of Li Wenliang, who was the whistleblower originally reporting that a SARS-like syndrome was affecting his patients in Wuhan. Dr. Wenliang was an ophthalmologist, and he was arrested for reporting online his observations and then released, but then died of COVID-19. This disease is affecting every state in the country, and cases continue to accrue. On June 6th, there were almost 30,000 new cases reported in the US. And it's been suggested that these may have risen following celebrations like Memorial Day. And we're all waiting to see whether the recent protests will lead to increased cases. I would direct you, and many of you are already familiar with the work by Thomas Pueyo. The shutdown in his thesis was the hammer. And this was quite successful in Massachusetts and in New York City, allowing us to better prepare, and that's the dance, for future surges of infections. That is by testing, contact tracing, accumulating the proper PPE, having protocols in place to deal with increases. But at the federal level, we appear to have abandoned even mitigation as a public health strategy. Now, COVID-19 and its manifestations have shown to us the inequities in our society and healthcare systems and have brought to light the structural racism that underlies much of healthcare in the United States. No matter how you look at it, this is filtered by all ages. The population proportions in our Black and African American and in our Hispanic and Latinx communities, also in Native American communities, the proportion those affected by the disease and the case fatality rates are much higher than one would expect from the population proportions alone. And in white Americans, the population proportion is about 60%, yet only about 30% of white Americans have been affected by the disease. And this is true across all age groups except the 75 and older, where the proportions approximate the population proportion, probably due to the outbreaks in assisted care centers and nursing homes. This disease across states has affected Hispanic and Latinos and Black Americans at disproportionate rates. This was particularly evident in this data from the New York City Department of Health, and even in the liberal state of Massachusetts. We know very well that surrounding areas like Chelsea and Everett and Revere have been disproportionately affected, and that our brown and Black siblings have been more affected than white Americans by this disease and by death. So why is this happening? Well, the underlying legacy of structural racism has made our minority populations more susceptible. They live in worse living conditions, more densely populated, farther from food and healthcare, certainly farther from testing centers. There are higher levels of environmental pollution, and we know that they're overrepresented in jails, prisons, detention centers, where crowding is the norm. We also know that Black and brown people work more in essential industries, whether it's service industries, agriculture, or even nursing. And finally, there's longstanding distrust of the healthcare system. We all know about Tuskegee. There are language barriers. There are financial implications of missing work to receive care when your finances leave you at the very margin. Hispanics are 3 times more and Blacks twice as likely to be uninsured in the US. And there's a higher prevalence of chronic diseases and higher death rates due to, honestly, structural racism in our system than in whites that once you become infected with the virus, make you more prone to death. So it's not without irony that I note the difficulty breathing experienced by persons with COVID-19 and the difficulty breathing with a knee on your neck are so closely connected. Not being able to breathe joins together a long list of what some in our society feel they cannot do freely. With that, I'll stop. Thank you so much.